Hello, I'm Dr. John Cruz, and today I'm going to be talking about Ozempic, the weight control weight loss medication. Is it any good for ADHD? So as usual, I'm going to start with the take-home message. The take-home message is pretty straightforward, that Ozempic and the related drugs, and this is a family of drugs called the glucagon-like peptide 1 receptor agonists, work quite well for diabetes type 2. They are quite effective for weight loss. They have, in general, fewer side effects than many of the other diabetes medications, clearly do wonderfully for that. There is a considerable body of animal research looking at, and I'll say Ozempic, even though some of the studies have been to other drugs in this class. It's easier. So Ozempic and other glucagon GLP-1 receptor agonists. Lots of animal research, rodent research indicates that they could be useful for Alzheimer's and Parkinson's. There are just a handful of clinical studies suggesting these agents may halt progression of those neurodegenerative conditions. There has been a moderate amount of research on Ozempic for addiction and addictive disorders. No clinical studies formally have done that, and absolutely no research that I can find on direct clinical models of ADHD, although there is some, particularly because Ozempic and its kin can regulate dopamine synthesis in the nucleus accumbens. That certainly is relevant to ADHD pathology, but there is a fairly considerable online and elsewhere anecdotal evidence that many individuals have experienced substantial help with ADHD symptoms from Ozempic. And it's not just the impulsivity or compulsivity. People have reported changes, improvement in attention, improvement in emotional regulation, and pretty much all of the core ADHD symptoms. So before I jump into more detail, I'm going to address a point that comes up here and came up in the ketamine talk last week. And that is, if we have all this great, compelling anecdotal information about how well drug X, Ozempic, ketamine, something else works for ADHD, shouldn't I be recommending it to all my patients? Or shouldn't you be recommending it to friends? Why the heck do we need these boring, controlled, double-blind studies to show that something works or not? And aren't we devaluating certain types of knowledge? So yes, there is important knowledge that can be gained from case studies, from observation, from anecdotal reports that can suggest that something might be helpful. But there's so much opportunity in all of medicine for placebo effects, for accidental skewing effects, for looking at small numbers of people and coming to erroneous conclusions, that right now the best way, I won't say it's the only way, is the reductionistic, looking at the drug in a rigorous study, comparing it to a placebo, not letting either the person taking it or the testers or evaluators know who's getting what, and studying enough people so you can really see if this is a statistically significant difference and a clinically meaningful difference. So yes, this is a narrower, more reductionistic type of information, but the importance of this is highlighted by the COVID epidemic. Separate from, and there are certainly actors and doctors among them who are political hacks and presented things because they were adamantly wedded to a certain viewpoint on how we should approach or not approach dealing with COVID. But there are also doctors who were desperate for something for their patients and recommended ivermectin, or their patients came to me who had taken ivermectin, who had taken hydroxychloroquine, and that patient did well. Or maybe they even had a dozen patients like that. Maybe they even had 50 patients like that. And then they felt confident. See, all my patients who took this are doing well. I'm going to recommending it. It must be helpful for mitigating serious outcomes from COVID. Now, part of it is that COVID wasn't a particularly highly lethal agent, even in the early stages where we had no treatments and little awareness and maybe more virulent strains. mortality rate was less than 2%. So in any study, you would expect 98% of the random patients to do well, or at least not to die. And again, fewer than 10% in most studies of people who caught the virus had serious complications or needed to be hospitalized. So you can get very misleading ideas from looking at small numbers of patients, or even what seem to be large enough. And again, that doesn't advance progress in medicine. It doesn't make for setting up good recommendations. That's what's likely to help people. So that's enough of my soapbox. Getting back to glucagon-like polypeptide type 1 receptor agonists, which is a mouthful. So what the heck does that even mean? So most people are pretty familiar with insulin. So insulin and glucagon are two kind of opposite working, not exactly, polypeptide hormones. So they are signaling agents. Peptides are protein-like molecules, so a string of amino acids, so fairly large molecules. Insulin is responsible for helping you move glucose from your bloodstream into the cells that need it for energy. Glucagon works the opposite way, which is to break down stores of glycogen into glucose, so boosting glucose levels in the blood and also engaging in gluconeogenesis, which is getting the liver to make new glucose. So glucagon simplistically is boosting glucose levels in the blood. Insulin is pulling it out of the blood into the cells and reducing blood levels. And we know there are serious complications from having too high glucose in your body. It causes damage throughout the body to anything with blood vessels in it, essentially. Glucose levels themselves, if they're too high, glucose spills into the urine, pulling water out of the urine, which is why people with hyperglycemia, glucose levels above 200, start urinating a lot. This can result in a significant electrolyte and osmotic imbalance and coma and death if it's severe enough. And glucose being too low can also be a problem, fainting to begin with, and death if there isn't enough glucose around to get into your blood cells. So regulation of glucose is important. Glucagon and insulin both do that. So what the hell is glucagon-like polypeptide type 1? So backing up a little bit, only certain groups of cells express significant amounts of glucagon in the body. So there is a progenitor molecule called pre-pro-glucagon. So this is a 269 pretty good sized amino acid that is made in intestines. It's made in the pancreas, which is where insulin is produced, and it's made in the brain. And numerically, more of it's in the gut than anywhere else. So this big, huge, long 269 pre-pro-glucagon molecule gets the pre snipped off, gets the pro snipped off, and then a less than 30 amino acid segment is made in some cells into the hormone, polypeptide hormone glucagon. From this, again, same original 269, a separate less than 30 amino acid sequence is snipped off in certain cells. This doesn't all have to happen in the same cell and that is the glucagon-like polypeptide. And then there's a third section that can be, again, these are not overlapping amino acid sections. A third one can be lopped off, and again, it's a little less than 30 amino acids, and it's glucose, I'm blanking on GIP. Gastroinhibitory polypeptide, GIP. So GIP and GLP-1 have certain actions. They're roughly similar, not completely identical. So they are polypeptide hormones themselves. GLP-1 has certain effects. So one, it boosts insulin secretion. So again, insulin secretion is going to help bring down blood glucose. Two, GLP-1 receptor agonists actually enhance the growth of the pancreatic beta cells that make insulin. So this is a slower term effect, but it's helping your body produce more insulin so it is more able to effectively control glucose, particularly when levels go high from dietary intake. And 3, it actually inhibits the production and the release of glucagon. So those are 3 different ways that the GLP-1 receptor agonists help lower and modulate blood glucose levels. And we have several different GLP-1 receptor agonists. They are all quite effective in doing this and thereby lowering glucose. But wait, there's at least 3 different things that GLP-1 receptor agonists do. Second thing is that they have direct effects on the digestive system, and particularly slowing it down, slowing emptying. That probably has some direct effect on decreasing appetite. The drugs themselves actually can cause about a third of people have nausea, about 10% have vomiting. They can also have diarrhea, abdominal pain, constipation. So those are probably part of how it results in weight loss as well. Controlling glucose certainly is part of the weight loss. But there's a third element, and that is, and this has been shown to be through brain effects, not through the rest of the body, but there are clearly appetite suppressive effects from GLP receptor 1 agonists. And again, these are effects for this whole class of medications. All of the drugs in this class are doing all these things. They might be doing them to slightly different extents, but it's part of why this became a popular and effective class of medications for treating type 2 diabetes. So type 2 is not completely insulin-dependent diabetes. I won't go into too much more about diabetes. So the first of these drugs actually came on the market in 2005. So 18 years ago. This is a long time. So that one was called Byetta. It was made by Eli Lilly. It was actually modeled after a polypeptide in Gila monster salivary glands. And it's a subcutaneous, so under the skin injection that you needed to take twice a day. Worked well for weight loss, worked well for glucose control, was only FDA approved for diabetes type 2 glucose control. But it works there. Does have, again, some gastrointestinal side effects. So jumping back, one thing I omitted, the half-life of glucagon receptor polypeptide type 1 GLP is only 1 to 2 minutes. It gets chewed up really fast by a specific kind of peptidase, which are enzymes that chew up polypeptides. Your body doesn't like to have big, chunky molecules floating around. Your body does a lot to chomp them up and digest them and reuse the pieces. So that actual GLP, again, less than 30 amino acid chain, 2 little modifications, and the different drugs in this class have slightly different modifications, but 2 of them were introduced to make a protein that would last much longer. So the first modification is to directly block the action of the specific peptidase that would break it down quickly. And the second one is to make these molecules bind more tightly to albumin, which is a circulating protein in the blood, so they last longer. So GLP-1 agonists, the synthetic drugs, have been engineered to have much longer half-lives. So rather than needing a continuous IV infusion, which you would need if you were taking the original GLP-1 receptor agonist, again, Byetta, the first one, you could go with just a twice a day injection. Over the next few years, and I'm going to have to read them all. So lixisenatide, also subcutaneous injection. Victoza, which is liraglutide, also subcutaneous daily injection, was released in 2010 by the company Novo Nordisk, which makes semaglutide, which is Ozempic. Trulicity came out from Eli Lilly in 2014, and that was a substantial advance in that they engineered a form that had a half-life long enough you could get away with weekly injections. Then in 2017, The molecule semaglutide was developed by Novo Nordisk to first subcutaneous injection only needing 1 week, so it was competing with Trulicity, and that was called Ozempic. Well, 2 years later, a form of it under the brand name Rybelsus, but most people still call it Ozempic, as a oral agent, and it's the only drug in this class that's an oral agent, came out. And then all of these indications were for specifically diabetes type 2. Actually, Victoza, liraglutide, did get an FDA indication for weight loss, but high-dose subcutaneous injections of Ozempic semaglutide were approved under the brand name Wegovy. And I'm going to throw it in, even though it's not usually lumped with them. So there's a separate drug called Mounjaro. It is both a GLP-1 receptor 1 agonist, like all these others, and it is also a GIP agonist. So it's a dual mode of action. Most of the evidence suggests that it is actually even better at weight loss, even better at glycemic control, blood sugar control. There aren't a lot of studies comparing head-to-head. There's about 14, 15 so far. And again, all these drugs are effective. If I were to oversimplify, the first one out, the Byetta, seems to be a little less effective at both weight loss and glycemic control, and a little more prone to causing some of the gastrointestinal side effects. Some of this needs to be taken with a grain of salt, and you'll need to look at which company sponsored which head-to-head study, because you could choose sort of different dosages as to what's really an equivalent. So again, they are all effective. And this is a billions of dollars a year industry already, because lots of people are overweight, lots of people have diabetes. The most recent incidence studies suggest we are nearing 500 million people on this planet with diabetes. That's almost 1 out of 16 people. That's worldwide, not just in the US, not just industrialized countries. We have created an obesity epidemic and a diabetes epidemic worldwide through our presumably changed eating and exercise patterns, maybe also because of environmental toxins. So there's a huge market for this. There's a huge amount that's been written in terms of mental health and obesity, mental health and losing weight. I'm not going to get into that. I'm going to get more into the neuroscience and using it to treat diseases. So I mentioned dozens and dozens of animal studies, and if you look at semaglutide, and I'm going to use Ozempic, although again, some of these were on other GLP-1 agonists. So these drugs have antioxidant properties in the brain. They have anti-inflammatory properties in the brain. They protect synapses. They actually promote making new synaptic connections between neurons. They're specifically strong at protecting dopamine neurons in the substantia nigra and preventing cell death. They prevent and reduce DNA damage throughout the brain. They increase the release of brain-derived neurotrophic factors and other neurotrophic, which they do increased cell growth, nerve cell growth. They have effects not just on neurons, but on glial cells, astroglial, other cells that compose our brains. So based on all this animal research, again, particularly looking at neurodegenerative benefits at stopping, reversing that, also effects on strengthening mitochondria and boosting mitochondria. There are tiny clinical studies on Alzheimer's and Parkinson's. These are not double-blind controlled studies, suggesting that these drugs may actually help in slowing or maybe even halting deterioration from those conditions. Now, some of the interest in Parkinson's is interesting and overlapping potentially with ADHD, in that dopaminergic cells seem to be having an extremely important role in ADHD and Parkinson's. And Parkinson's, we're focusing mostly on the motor system for dopamine with cell bodies in the substantia nigra. With ADHD, we're looking more so at the mesocortical reward system, dopamine system. But again, there are studies showing that GLP, Ozempic-like drugs do have potential effects on dopamine in the nucleus accumbens, which is an important part of that mesocortical reward dopamine system. So a couple caveats. One is, again, these different drugs may have different abilities in terms of how well they penetrate the central nervous system. So again, although they're all good at their overall weight loss, glucose control, how strongly they're working in the brain may well vary among them. And again, lots of the basic research was done in rodents, and it's quite clear that in different, comparing rats to mice, some of these effects are found in one species and not the other, and human brains are even less similar than rats to mice are. So whether all of these changes, whether all these effects will be found in human brains, it's hard to know. Given the effects on the dopamine reward system, there's a lot of small amount of research, less than for the neurodegenerative things, and lots of speculative, suggestive essays, scientific writing about these drugs may be powerful, and writing in the popular literature. So the New York Times has done articles, the Atlantic has done articles as to whether these drugs may actually be substantially helpful for alcohol and other substance abuse addictive disorders. So anecdotally, again, from lots of patients who are taking these for control of weight and diabetes, but also noticing that it helps impulsive, not just eating behaviors, gambling, drinking have been fairly commonly noted. I don't know any study that's even just surveyed people taking this for weight loss or diabetes to see the rate of people noting improvement in these other areas. And if you go on the internet, if you go on Reddit, if you look at chain drug pushing entities that are pushing people to take Ozempic and other medications, you can find websites that say there's scientific evidence that this helps for ADHD. I would say that's fairly basic. Again, things like this can modulate dopamine systems. We don't have any clinical studies. We don't even have anecdotal case reports that I can find written up about ADHD benefit, but there are powerful, glowing, again, anecdotal reports of, I used to lose control and due to my ADHD, and now I don't. I don't engage in risky behavior anymore. It completely controlled my temper tantrums. It helps me with motivation, helps me be clear-minded, helps with impulse control, concentration, staying on track, being productive, emotional dysregulation. I'm repeating myself. I went through lots of individual comments. And many people comparing it to more profound effects than they got from stimulants and much less revved up agitation, anxiety. That's a segue. I did not mention side effects. Some people have been worried. Animal research, again, suggests there may be increased rate in thyroid and some other endocrine tissue and endocrine types of cancers from these agents. So far in the human data, this has not been showing up as a particularly clearly associated risk with taking them. That doesn't mean there aren't individuals, and there are clearly lawsuits who are trying to find as many individuals with these kinds of cancers to sue some companies, but it is clearly not a strong association or one that's come out. Again, the common side effects are gastrointestinal acute effects that you would associate if you substantially slow down gastric and intestinal emptying and processing. What else? So other side effects with all the injectable forms, and again, there's the only non-injectable is a form of semaglutide called Rybelsus. Again, most people are calling it Ozempic, at least on terms of blood glucose control and weight loss. It does seem less potent than the subcutaneous weekly version of Ozempic. But again, whether we're really using equivalent dosages or not is a debatable question there. So right now, I would not recommend. So I do have at least one patient who took this specifically for her ADHD. She has, according to her and her partner, so there's corroboration, dramatic effect, and loses that effect within a day or two of stopping it. So she had emotional regulation, impulse control issues, poor planning, poor organization, poor prioritization, poor motivation to change this. All that seems to be better. She feels it's as strong, at least, as the effects she's gotten from stimulants. But I think we need more data to know, again, how maybe there's only certain subsets of people with ADHD who are going to benefit. Maybe, again, this is not even a statistically meaningful rate of improvement. She clearly had expectations that this was going to help because she's neither overweight nor diabetic. So she had to go through some effort to find a part of the medical system that was willing to prescribe it. And again, not just prescribe it, but prescribe it at a time where there are substantial shortages in all of the drugs in this class throughout the country. The demand is substantially exceeding supply. So time will tell. It's again, there are certainly basic science reasons to suggest this could be helpful. It may be generally helpful for lots of people. We will see. That's about all I'm going to say for that topic, unless I'll check the questions. Next week's topic is ADHD in jails, and there is a strong correlation in most studies as to having ADHD and winding up in jail. So we'll talk about that. So, hello, Dennis. Dennis asks, can benzathymine treat ADHD? So I am not sure how many. I think there are actually some older research. So I'd say the answer is all the drugs that are stimulants, including things like phentermine that are not as tightly regulated, low grade stimulants, or considered to have lower potential for addiction and other abuses. Any sympathomimetic, any stimulant that's promoting norepinephrine and or dopamine release or action does seem to have benefit for ADHD in a considerable, more than half the people who take it. So Mr. AKA 1996, how often do you see guanfacine XR also benefit comorbid anxiety disorders in ADHD patients? So I do have a separate talk on guanfacine. There's a bunch of questions embedded in there. I've certainly seen many people who took guanfacine who are also, I guess they're not even asking whether they're needing to take they're on a stimulant simultaneously. So I've seen guanfacine either alone or with a stimulant reduce someone's anxiety symptoms. I think there are many people with ADHD who have anxiety as a direct result of their ADHD. If you can't keep track of your own thoughts, if you're not sure where you left your suitcase or your soup spoon or your daily medication, if you're afraid of getting off track, if you're afraid of repeating yourself excessively in conversation or skipping important information, that's going to increase the likelihood you're going to feel anxious in social situations. It's increased the likelihood you're going to worry. So I think there are some people who have completely separate anxiety disorders that happen to co-occur with ADHD. And I think there's some anxiety that is a direct byproduct. And I've also clearly seen individuals who in their 50s who were told from childhood, you have an anxiety disorder, you have an anxiety disorder, you have an anxiety disorder, who primarily had ADHD. Their thoughts were going a mile a minute. There's a lot of overlap between hyperactivity and anxious fidgeting as the real. So we have issues of, do they really have an anxiety disorder? Is it a manifestation of their ADHD? Do they have an anxiety disorder, or are they just responding to their ADHD with anxiety? Guanfacine in general seems to treat, for many people, certainly not all, a whole range of anxiety spectrum issues. So I hope I answered that. So Dennis asks, just curious, what was your undergraduate major? His is chemistry, and he's planning to pursue a PhD in pharmacology and MBA in marketing. I'm more cheering on the PhD in pharmacology, less so the marketing, although that's part of our world. And so I was an undergraduate in just 3 years in an era when that was pretty weird. And so I was a biology major, but I actually avoided most of the pre-med regular classes. So I took physics with the physics majors and chemistry with the chemistry majors, and was a biologist. At one point, I was equally likely to be a naturalist, an outdoor biologist. Went in the medical school direction, then was accepted to an MD PhD program and did my PhD work on circadian rhythms and specifically the serotonergic innervation of the suprachiasmatic nucleus, and that being essential for the effects of certain antidepressants on the circadian clock. And then after residency, wound up going into purely clinical psychiatry for various reasons, and developed my interest in ADHD with one of the very first patients I met who had profound ADHD, had not made progress in 7 years with a very skilled and experienced psychiatrist who was a Freudian psychoanalyst, and then was evaluated at UCSF, one of the top medical centers in the country, with several days of neuropsych testing. And they said, if this were an 8-year-old kid, we'd know he had ADHD, but that doesn't exist in adults. This was 1994. And already some people were aware that it existed in adults. So this person was sort of handed off to me, and I kept seeing symptoms that looked like ADHD, and there were elements of depression, there were elements of substance abuse, but the ADHD was so pervasive and so severe that I needed to start doing my own research. And I've actually, in terms of severity, picked on this person as an example. So he's my example also of, he had more than 100 jobs by the age of 30, 40. He was already on disability when he started working with me because he was above average intelligence, but he was so distractible that even as a checkout cashier at grocery store clerk, he would start talking to people like, oh, wonderful earrings. Where'd you get them? I like turquoise too. He would, and then his line would be 3 times longer than all the other stores. People who were directly interacting with him liked him. The person in back of that, 3 people back, didn't like that. And then the other, why he would lose the job as a cashier is that he'd also get so involved in talking that, did I just hand you the $20? And this is when we were mostly a cash-based society. Did I give you the 10 or did you give me a 5? And enough people would lie to him and take advantage that he couldn't keep track of whether he had just given them change or not, or which size bill. That at the end of the day, his till was always short. His lines were always longest. It's pretty easy to find people who can do the job of a grocery store cashier. So they would, I'm not going to keep paying this guy to do the job that he's not really doing. So that's maybe more of an answer than you wanted, but there it is. I'm not seeing any more questions coming in. So bottom line, I would not say we have evidence yet to be recommending semaglutide, Ozempic, or any of its cousins for ADHD, but we might down the line. So stay healthy, stay happy, and I'll be back next week at the same time. And hopefully in the next week, I will get the December schedule out. That's all.